we report on a project that I've actually been working on for basically 30 years. And Neil just left the room for a second. Neil Schreiner is actually a big part of this project. But it's always struck me in medicine that we have this specialization that allows us to do literally miracles for people, but it also fragments us. So we have all these resources at Swedish, but we're not necessarily connected together to optimize the outcomes. And so we developed this database process over the last 18 months. And Swedish gave me this young intern who's turned out to be a bit of a prodigy, Kevin Clower, who's helped me put this database together. And it's been unbelievable what he's been able to accomplish over this last year. So the idea was to present the development of a fully automated database that is clinically relevant and researchable, with clinically relevant being the first priority and researchable being the second. And we call it the SNI Surgical Optimization Project. It really turns out to be just simply taking care of spine patients in general. And my thing is better outcomes through accountability is my thing. But you first have to define the problem. And most of you in the room have read my book. I understand I wrote this book on chronic pain. And it turns out chronic pain is complicated. Medicine has a tendency to throw simple solutions at complex problems. It cannot work. And the analogy I use is like a prism. A chronic pain is very complex. Human beings are complex. It's like staring into a very bright light, and you can't see what's inside. And so what these frameworks do is they simply create a prism on the other side. It's a prism. It creates a light on the other side. Each human being has their own spectrum of pain. And so once they see the problem, by definition, if it's a complex problem, only that person can solve the problem. So we start throwing injections and epidurals and surgery at these people, you're not going to solve the problem. Now, you can be adjuncts to it. There's never one solution for a complex problem, and there's never somebody else's solution for a complex problem. It has to be that person's solution. So the idea is simply create awareness of the problem with every patient every time. So basically, the basic problem is that chronic pain is not acute pain. And there are hundreds, maybe thousands of research papers now that show this to be true, that chronic pain is a neurological diagnosis, not structural. And once it becomes a memorized pathway, it doesn't matter what you do. So this is one paper which caught my attention out of Chicago, and these guys publish 2 to 4 papers every month on this. But basically, it's called shapeshifting. Chronification of back pain shifts brain representation from nociceptive to emotional circuits. And the study prospectively looked at acute pain less than 2 months in 94 patients, then looked at patients who had pain more than 10 years, 59 patients. And they noted on the functional MRI scans that the acute pain, of course, went to the nociceptive area that correlated with the back. Chronic pain went to the emotional area, and there was no overlap. Then they longitudinally followed all of the acute pain patients and noted that 19 recovered, 20 became chronic. That should catch your attention right off the get-go because we're told that 10% of patients go on to chronic. In other words, 90% of people get better over time. This group, 50% became chronic. Okay, so I'm not sure where that data came from originally. And what they found out that in those that resolved, that the nociceptive area of the brain diminished, and there were no other changes. In other words, the reward center stayed the same. And those that became chronic, the activity shifted to the emotional centers, but the nociceptive region diminished or became absent. Every patient, not subtle. So basically, chronic pain exists in the emotional center, not the nociceptive centers of the brain. So we know that anxiety and chronic pain are linked. It turns out the neuroscience shows that anxiety is the pain. Mental pain and physical pain are processed in the same way. They are permanent pathways. They're processed in the same area of the brain. So if you're doing a surgical procedure for a neurological problem, can't work, not going to work. And all of us are familiar with phantom limb pain, which is fascinating to me since I was a resident. And think about that. I mean, that's a big deal. I have not dealt that much personally with phantom limb pain in the last 10 years, but it's a pretty big deal. People are pretty frustrated. They can't touch the leg to distract themselves. The pain is the same. That's a big deal. And any surgical procedure that you do is not going to make a difference. There's one study done a few years ago on 11 patients where a hand surgeon amputated 11 normal arms in patients who had arm pain. Guess how many got better? Didn't happen. They had normal functioning arms. They amputated the arm, pain didn't go away. I think 1 patient, 2 patients got a little bit better. That was about it. Yes?
Yeah, you said that you were, I think, 50 patients that got better and half of them went on.
Correct.
Were these post-op patients?
No, they're just acute back pain. Just acute back pain, right. Nothing surgical in that group. Same thing with the chronic pain patients. Surgical patients were excluded from that group.
Did you look at the causes of the back pain? Were they the same in the two groups?
You know, I don't, it's hard to say. I don't remember that part of the paper.
You know, say the 50% got better at herniated disc and the ones that got worse were just sprains or degenerative disc disease, that would make a difference.
Well, again, the data shows really clearly that, disc degeneration, arthritis, and bone spurs have nothing to do with back pain. I mean, that data is really clear. So regardless of the cause of the pain, and it turns out to be true in any body part. I mean, it doesn't matter which part of the body that you look at, it's the same situation where you go from nociceptive centers to the emotional centers.
A lot of patients complain about pain, degenerative disc disease. Maybe it doesn't cause pain, maybe the pain is emotional, but they come in complaining of it.
Well, again, I can talk for a week on this, as people in this room know, but I don't use the word psychological. I mean, this is a neurological process where your brain, we exist on this planet by processing sensory input, right? So we're sitting in the room, temperature is good, noise is okay, we're avoiding bright lights, et cetera. So that's how we exist on this planet, is that the nociceptive center actually keeps us in a safe zone. When we actually feel pain, it's actually not the nociceptive system, it's failure of the system. In other words, we exceeded the nociceptive boundaries for safety. Turns out that thoughts do the same thing. Thoughts go to the same part of the brain. So let's go to sensations for a second. So you have nice sounds, symphony, warm beach. Your body secretes dopamine and oxytocin, and you feel relaxed. When you feel relaxed, you're just feeling the chemical surge. Bright lights, loud sound, your body signals danger, and you have adrenaline and cortisol, then you feel anxious. Anxiety is not a psychological problem, and so it turns out that thoughts out of the same group in Chicago go to the same spot. So pleasant thoughts give you reward chemical, unpleasant thoughts give you stress chemicals, then you feel anxious. The problem that humans have compared to other species, you cannot escape your thoughts. So when you suffer, suppress, or mask your thoughts, you're screwed. So that's why probably the basis of chronic pain is going to be this progression of thoughts throughout your lifetime. They get stronger with repetition. You suppress them, they get worse. Masking doesn't work, so what do you do? The reason why it's so critical is to understand the emotional pain and physical pain are the same thing, is that it's part of the unconscious part of the brain. So if you want to treat this anxiety, whatever you want to call this over here, psychologically, you're screwed. Because the unconscious brain is 1 million times stronger than the conscious brain. You have no chance. So it's again a whole different topic, but all sorts of things affect the perception of pain: sleep, stress, physical conditioning, diet, and nutrition. So that's why chronic pain is so complex, is that if you're not sleeping for 3 years, then offering somebody spine surgery, that's not okay. There's a study out of Israel that showed that lack of sleep actually induced chronic pain. It was not the other way around. So going to back pain, there's multiple studies showing that there's no correlation between back pain and disc degeneration. But then again, it doesn't matter, and we'll show this later in the talk, it doesn't matter where the pain starts, structural, bone spurs, tendonitis, whatever it is, the brain memorizes the pain. A little off track there. How's my time? We also know, that we think we can sort of figure things out. The surgeons sort of know in clinic if somebody's, risk-free or has the risk factors for chronic pain. And they noted on the European Spine Journal, but also out of Salt Lake City, that surgeons can figure out chronic risk factors about maybe 25% of the time. It does not matter whether the physician is medical student, junior resident, senior resident, junior staff, senior staff, it doesn't matter. You cannot tell in a busy clinic who is under stress. We're also ignoring the guidelines. So right now, we become a production culture, and the paper out of Baltimore shows that less than 10% of surgeons are actually acknowledging the fact that these outside factors have an effect on pain before they do the surgery. So what you're doing, you have a neurological diagnosis. We don't have good data that show that spine fusions work very well for back pain. And then we're adding on the stress of surgery. And every day in my clinic, 2 to 4 patients come in and they're worse from prior surgeries. It doesn't stop. So what we're trying to do is create an awareness of these factors automatically. It turns out that actually treating chronic pain is actually incredibly time efficient. It does not take time. So you use questionnaires. The patients take full responsibility. They treat every aspect at the same time. And we have hundreds of patients going to pain-free. But the first step is to create an awareness of the variables. So what we did, the idea with this database was to use standardized tools to identify risk. We wanted it automated. We did not want one human being in this whole process at any point in time to make this thing work. It would fall completely apart. Not one person is in the system. We want focused use of resources. We have the resources. We don't want all the resources being used on every patient every time. Remember, everybody has an individual chronic pain spectrum, and so sleep might be fine for me, not good for the next person. So we wanted to define the issues. We wanted to monitor the changes in risk factors. So obviously the follow-up questionnaire is going to match the intake questionnaire. We're doing patient-reported outcomes. And again, Neil came back in the room. We're trying to link up with his database. And we designed it to work with the SCOPE database, which I think most of you are familiar with. Then we're trying to analyze the links. So what I found out years ago, I actually had 15,000 patients on a database here at Swedish. And we found out we're just overwhelmed with data. Data doesn't change anything. There's sort of this battle cry, just collect the data, give me another paper. There are hundreds of papers showing that sleep, stress, physical conditioning, diet, nutrition, all those things make a difference, but we are not operationalizing those factors into clinical practice. So my personal focus is taking what we know and let's just do it. So then let's look for the additional resources. And right now, so what we did, I developed 8 work groups, and I'm just going to run through these really quickly. We wanted the IRB to have a broad consent. So if we wanted to research the database, we did not have to go back and redo the IRB. So we got a fairly specific but broad IRB going. We put a request for proposal out for different platforms. We looked at 10 different vendors. Turns out that Providence was using what's called the Tonic platform. It doesn't really matter. As long as you have a generic database that can collect data and analyze it, you're fine. We wanted the metrics to be across pain, physiatry, and spine, and eventually primary care. We wanted a dashboard, which I'll show you in a second, which would automatically be populated by the intake questionnaire and follow-up questionnaire that identified the risk factors. The output is what we're working on now. The output we're describing as the resources to treat the problems. So right now we have a smoking program now developed. We are pushing our sleep center to develop educational resources and a protocol to come into the sleep center. We're actually developing a workforce now between primary care, physiatry, pain, and spine to develop sort of a massive spine care system. We found out we took care of 29,000 patient visits last year for medical backs. Guess what? 4 spine surgeons are not going to take care of that. And there's also that reflex of, well, patient has a spine problem, not doing well, send them to the surgeon. That hasn't worked. The implementation team, we had 4 nurses get together and tell us how to put this into the clinic, make it work. The reporting we're working on now, we want to create a story that makes sense on a weekly basis that tells us how we're doing, how we're not doing. But also every patient, every time. When they come into clinic, there's a visual dashboard that tells us how this patient's doing. Then the research is the final thing, which is a combination of registry and high quality research. So this is a spine questionnaire that a friend of mine, Stan Herring, and Jim Robinson and myself developed 30 years ago. It's gone through over 22 revisions. It's worked incredibly well. We mail it to the patient before they come into clinic. It takes about 45 minutes to fill out. And literally in 90 seconds, I know the problem. I spend about 5 or 10 minutes with the patient getting the symptoms, reviewing the films in the clinic with them, spend about 10 or 15 minutes with them talking about situations. I'm done. I'm actually door to door in about half an hour. Okay, incredibly complex patients. I'm not spending that much time because the questionnaires help us. The technology helps us. I'm not necessarily proud of that. Okay, it's not my goal to do time, but guess what? You can do this in a short amount of time. But this questionnaire will tell you everything you need to know. But it's paper, it takes a bit of time. So we wanted the intake computerized platform to be clinically useful, number one, by far and away. In other words, we didn't want just research questions. We wanted to create a dashboard and then finally researchable. And those are criteria that we stuck by, and we took no prisoners on this one. So this is a mock-up of the dashboard, and you see there's sleep, stress, medications, nutrition, smoking, I can't read that one, glucose. And the dashboard is under construction. We have a 6-month delay in Epic with their rebooting the system, but we have this dashboard started with smoking and sleep, and then opioids being the third we're going to start with. So the patients fill out their follow-up questionnaire. So if their sleep questionnaire shows high risk on initial intake, they come back 3 months later and their sleep factors have normalized, this dashboard will automatically go from red or yellow to green. Now, we're not trying to be draconian here. If a surgeon wants to operate in the face of 7 out of 7 red flags, we have data. But we're going, why? Because we all know the risk factors for poor outcomes. So this is, again, automatic. You see to the right, there's the scope database, which we're having some political issues with, but we still like to work with the state database. And what we're doing, we're collecting generic data for the last 3 months, which I knew would happen, that we have all this data, but no story. We don't have a database that's defined well enough to tell the story. But we're at least collecting the data, and we're getting ODIs, pain scores, sleep factors, anxiety, depression on every patient. And then we're looking at the risk factors, and we're looking at the impact of our interventions. We're not there yet, but we have built the machine. So for instance, with the intake questionnaire, it takes about 20 minutes to fill it out. It's on the web. You can also do it on an iPad in the office. It takes about 20 minutes instead of 45 minutes. Patients like it. It's really simple. It pulls right up on our computer. You can just sort of look through it first in front of the patient. It takes about a minute, minute and a half. You have the story. You have the same story you had on the paper questionnaire. But we also spent over 200 hours crosswalking the different questionnaires. So our questionnaires are valid. Neil spent a long time with us on this. They're researchable. And they're also, my dream was to get pain, physiatry, and spine actually talking to each other, which we did. So we're all in the same database, which is a big deal.
So are pain and primary care and spine, every patient, every baseline, there's a red line hard stop if the baseline's not complete?
Well, that's the goal. But I mean, yeah, we don't, yeah, no, they're all, so pain and spine are now in the database. We went live with the final questionnaire about 2 weeks ago. I would probably be a year before we fully implemented the project and get the dashboard going. But there's a huge commitment now amongst all services to make this happen. You know, when you have a common database, there's a lot of power in that. People can talk to each other. So we've had a rapid adoption. People are excited about this. Neil?
The hard stop comes next year.
Well, you say hard stop, we'll have the databases. Well, I mean, we'll have the data that have the dashboard. So again, if somebody wants to operate in face of 7 red dots on the dashboard.
No, I'm thinking from a baseline entry perspective, because if you have the baseline, you are gold.
Oh, we have a hard stop now.
You have a hard stop.
Oh yeah. Every patient that comes into the clinic fills out the questionnaire. It's not hard. Yeah, no, it's done. So that part we have. So right now we're trying to optimize patients, and I wrote my book 4 years ago in 2012 saying, look, if a person in chronic pain has a bone spur and radiculopathy, do the surgery earlier because the people in chronic pain don't tolerate more pain. Turns out I was wrong. Turns out the data shows that if you operate on somebody who has chronic pain pre-existing and you do any operative procedure, for instance, if you have chronic neck pain and you do a hernia, you can induce pain at the hernia site 40% of the time. 10% of the time that can become permanent. If I told you I had a neurological complication rate of 10%, I would not be in business, right? So people don't really, I didn't know that until about a year ago. There's a bunch of papers that document if you operate in the presence of chronic pain, you can induce chronic pain as a complication of the surgery in the new surgical site. And of course, you can make prior pain worse. I can never understand why I would do this perfect operation and people would get worse. I mean, I did it, right? I'm the guy. And so what happens, you have these chronic pain circuits fired up, you start plugging in body parts, okay? So what's happened, which is a problem, is that I'm now almost up to 100 surgical patients with severe spinal stenosis that if they've gone through what we call a prehab process of 8 to 12 weeks, which is sleep, stress, medication management, et cetera, they cancel the surgery. So I've literally lost 100 patients in about 2 years that get better without the surgery. Here's one. I mean, that's a pretty tight canal, right? Did the prehab 8 to 12 weeks. She was very much of a cynical person, did not want to do any of this. She's fine. She canceled the surgery. This guy, I actually put him on the surgical schedule early because he was so tight in a wheelchair. And I said, look, he wouldn't participate. I said, fine, we'll do the surgery anyway. And he got sick. He started doing the process. He said, look, I'm feeling a bit better. I said, well, you still want to do the surgery, don't you? He goes, well, yeah. Anyway, long story short, he canceled the surgery. 3 years later, he's in the hills hunting elk with a 4mm canal. He's doing fine. We all hate this questionnaire, okay? Right now, it's an easy diagnosis. The whole nervous system's fired up. You know it's not a structural problem. Okay, and all of us hate that questionnaire, but it's actually become one of my favorite questionnaires because guess what? Send her to my pain guy, David. She has made remarkable changes. She is motivated and has developed a strong internal locus of control. She has chosen treatments that have helped her and is focused on conversation, a huge change. She gets advice and help from all of us. Really wonderful, Joel. So we hear this story all the time. May not happen in a day. Her took 2 years. We have some people going to pain-free in 2 weeks. So it turns out when you start calming down the nervous system, people go to pain-free. Disease in man is never exactly the same as disease in an experimental animal. For in man, the disease at once affects and is affected by what we call the emotional life. Thus, a physician who attempts to take care of the patient while he neglects this factor is as unscientific as the investigator who neglects to control all of the conditions that affect his or her experiment. So I read that for years. It's written, one of the essential qualities of the clinician is interest in humanity, for the secret of care is caring for the patient. And that was written by Francis Peabody, who you probably read this paper in 1927. But what we now know through the neuroscience research is that when you're under stress, it changes the body's chemistry. You're under a sustained adrenaline attack. There's over 30 symptoms of a sustained adrenaline attack. And until you calm down the nervous system, to add on the stress of surgery doesn't make any sense. Thank you.